Viewers, Assalamu alaikum. Today we will be teaching you insulin preparations, comparative effectiveness of pharmacotherapy for diabetes mellitus. So let me proceed. You are quite familiar that diabetes mellitus is a uh, full-fledged pulmonary disease which involves hyperglycemia. So the types and key symptoms of diabetes mellitus is that there is insulin-dependent diabetes mellitus, non-insulin dependent diabetes mellitus, then some gestational diabetes mellitus, insulin-resistant diabetes mellitus. But this classifications is has been there have been addition of numerous clauses. Nevertheless, these two are very old: insulin dependent, non-insulin dependent diabetes mellitus, which is also called maturity onset diabetes mellitus as well. So regarding cardinal symptoms, you see that is the polyuria, polydipsia. Of course, it's a reflex phenomena, and then you can say polyphagia, and sometimes neurological symptoms as the disease progresses. But we are mainly focused on polyuria, polydipsia, because this polydipsia is a reflex phenomena. So, and since BMR is high, it is polyphagia, and the neurological symptoms are sometimes ignored. But these are technical point to remember for a very intelligent health professional. Now, having said that, this slide describes the insulin preparations. Of course, that's to be given either subcutaneously or intravenous or in infusion, as the case may be. But these types of insulin: fast acting, intermediate acting, and long acting. And look at the onset of action. The onset of action of fast acting is usually that's 1 hour, you see, and then for intermediate acting, the onset of action is 2 hours. This is important, particularly for the onset of action, especially once your patient will be taking food and there is postprandial glucose shoot up. Usually that happens in first 30 minutes to 1 hour or 2 hours. So this will determine the fate that how you are going to combine the fast acting or regular insulins, or the intermediate acting and long acting. We will be focusing on that. But look at this. The long acting insulins onset of action is usually 4 to 6 hours, whether it is protamine, zinc, or extended zinc insulin preparations. This column is going to tell you regarding the time of action and the time of injection. So you see for which particular duration the regular insulin works, and that is usually 5 to 7 hours, and it is usually given before breakfast. But regarding zinc suspension, you see, then it becomes the onset of action is though 1 hour, like this for both regular and the prompt zinc preparation, yet the duration of action is prolonged, especially once you add zincs. So this is a technical point to remember, and this duration of action will determine the fate, especially for selection of different type of patient, to give them a different type of insulin preparations. This is a time of possible hypoglycemia risks, and that is late morning. And of course, since the duration of action is prolonged, so then it goes to late morning or mid morning, you see. And once you go for, as it is more increased, so this is the now late afternoon or bedtime. So this is how you will read this slide. Now let me proceed to clinical situation. Now you may be having 3 different type of patient. This is patient 1. This is the blood glucose level is plotted on the y-axis, and time is on the x-axis. And you see this is patient 1, and there is the if we consider this fasting blood glucose level, so this above 110 till this 120, that's pre-diabetics, and on 20 or 125 you see milligram per deciliter. So you can say that above 125, to make it simple for you people, so the patient may be called as diabetic, suffering from diabetes mellitus. So Regarding patient 1, once your patient is taking this food, so the blood glucose is now shooted up, and once it is shooted up, so it follows this pathway, meaning that there is a technical point to remember that the kidney threshold is 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 uh, is 180 milligram per deciliter, and if this is the kidney threshold, 180 milligram per deciliter. So a level that is above the kidney threshold, you see, this is above the kidney threshold. So if you draw a perpendicular from here, this is usually 1 hour, and then here you see, so for almost 1 hour, this particular duration of time, it will start appear in urine. So pre-lunch, in pre-lunch urine, you can find that the possible glycosuria or the glucose that will appear in urine. Contrary to this one, this patient 2, and you can see that his blood glucose level is above from the early morning, that is 125 milligram per deciliter, and this is the area under this curve for this patient 2. And if you think that, so it goes to 125 milligram at till 18 hours, and now till 18 hours this will decide the fat, and especially this for patient 3, if I draw perpendicular, so at 24 hours this is above the 125 milligram per deciliters. So I carry you back. So the onset of action of intermediate action is 2 hours, yes, of course, but the duration of action is 18 to 24 hours. Now if I carry you back to that particular patient, since onset of action is 2 hours for that intermediate acting, so this 2 hour is coming first. This is coming first. This phase is now before, you see, this is before, especially so once the above 180 milligram per deciliter for this 1 hour. So if you give intermediate acting insulin preparation, so it will start working onset of action after 2 hours or up on 2 hours. So before this 2 hour, for 1 hour, this GFR, the blood glucose will filter into the urine at the level of kidney through the GFR, glomerular filtration rate, and then you can say glycosuria will still persist. So what you have to do, you have to combine this regular insulin where the onset of action is 1 hour, so this will give you a backup, or you can give it late morning. So what happens, you can give a insulin preparation that is usually intermediate acting insulin preparation, and that is from duration of action 18 to 24 hours. So per patient, this particular patient, that's reducing the duration is for 18 hours per patient 2, the best suitable preparation will be intermediate acting. But you have to cover which one. You have to cover this initial phase. So therefore a good clinician will combine some regular insulin preparations to cover or back up the initial postprandial shoot up, you see, and plus a combination of either intermediate acting or long acting insulin. But look at the onset of action of long acting insulin, that is for 4 to 6 hours. So for that you have to cover this initial 4-6 hours where the onset of action is. If I draw it for you, this is patient 3 now, this green line, and usually after 2 hours, you see, after 2 hours this reaches the kidney threshold, and then for after 2 hours till this mid of 2 and 4, this is, you can say, this 3 hours for next 1 hour, so the glucose will start appear in urine. So what to do, you can combine now regular insulin to cover this region from 1 hour till this initial 3 hour time. So you can give regular insulin for this patient 3, and then a combination of long acting this intermediate acting insulin, because it is going to cover this particular and for this particular duration of action of time. So, in nutshell, uh, what is the message? The message is for a patient like patient 4. You see, this I have presented this with a red line, and this red line, you see, it means that almost all the time this patient blood glucose level is above 120 milligram per deciliter if it is passing. So you see, so almost the time the glucose start appear in urine. So whether that is pre-lunch urine or pre-bedtime or dinner time urine, so that will start appear in urine. The glucose will start appearing in urine. There will be glycosuria. So what is the technical point? The technical point is you have to give long-acting insulin, and that is why probably this is the reason that you have to give this long-acting insulin during the night and so do at breakfast. Sorry, but the point is that you have that the time of possible hypoglycemia risk is during the night till the breakfast. This is a technical point to remember. So these diabetic patients who are on long-acting insulin, they must be educated about the possible time of hypoglycemia, and so that they shall have some remedials and some cookies or some other preparations for a possible hypoglycemic prodrome, so that the poor patient should not go to may not go to hypoglycemic shock. Now I hope now you understand that which particular insulin preparation will be suitable for which particular patients. So this will make your knowledge more sound for rational selection of insulins. Now regarding the doses, you see, I have placed this for your better understanding. This the same previous graph here, and then there is the, remember, this is mature. This individualized dosing is for diabetes without complications, and the dose should not be should be less than 40 units per day. Mean that initially you have to adjust all these things within 40 units of insulin. So initially you have to give it to 10 to 20 units before breakfast, and check the urine whether it's going to appear in urine glucose is going to appear in urine. So urine glucose in fasting, pre-lunch, pre-dinner, and bedtime is then checked. The dose of insulin is raised by 4 units, but remember, this is a technical point, every 3 to 4 days. Remember, this is without complication. In case of complication, you should make some robust dosing, so that to bring the blood glucose level below 300 milligram per deciliter, and then you can proceed for the other necessary action as well. But since we are without diabetes, now we're dealing diabetic patient without complication, so you have to follow this step 3, then, that the dose of insulin is raised by 4 units, but every 3 to 4 days, not every day. Remember, this is what we usually commit blunder and mistake. As long as glycosuria persists, so we can increase the dose till a maximum point, and that is 40 units per day that is reached. If glycosuria still persists in pre-lunch and pre-dinner, so a small dose of regular insulin is added, as I discussed in the previous slides, especially for this particular moment, that once the kidney threshold level is increased. So it's going to cover this for patient 2 and patient 3, you see. But for patient 1, since this is for a very small period of time, so I will suggest lifestyle modification. But for patient 2 and patient 3, you see, we will cover this initial backup that goes post for the glucose shoot up, so with some regular insulin as well. Remember, in case of maturity onset diabetes mellitus with complication, the presence of infection like stress and the ketoacidosis, all these points have to be kept in mind, and you have to adjust the dose. So the individualized dosing is best. Usually you will be dealing with diabetic patient without complication and with complication, and you have to adjust the dosing. This slide describes the comparative effectiveness of some pharmacotherapeutic agents for diabetes like insulin secretagogues, sulfonylureas, and here is a oral preparation, begonides and alpha glucosidase inhibitor, thiazolidine dione derivatives, and then the medical nutrition therapy and physical activity. Nowadays people are working very much working on this, but I have put this slide here just for your good understanding that, remember, anticipated reduction in HbA1c, and so the percent reduction in HbA1c is, you see, so this medical nutrition is as effective as sulfonylureas, you see, and begonides and sulfonylureas, remember. But what is the technical point? The technical point is that physical activity and lifestyle modification mean, and this nutrition therapy is as effective as thiazolidine derivatives. So what the message is, if this is as effective, physical activity and medical nutrition is as effective as thiazolidine derivatives, sulfonylureas, then you should at least advise your patient about lifestyle modification, because this is a technical point. Usually diabetes develop in persons with the who have a sedentary lifestyle, whose stress is not controlled, and of course sleep is disturbed. Now, having said that, look at this alpha glucosidase inhibitors, and that's not as much effective as physical activity, as begonides or as sulfonylureas. So if this medical nutrition and physical activity are as effective as the other class, so I will prefer this particular modalities first, then followed by the oral therapy. So in summary, never treat the symptoms of the patients like fasting blood glucose level and HbA1c. Always I would suggest treat the patient's overall disease profile while looking into patient profile chart. Always ask patient for stress component lifestyle modification, as I did discuss early. Regarding stress, we have already uploaded a video that is with the stress and the role of cortisol where the negative feedback fails. So you can find the detail of stress, that how stress develops in this materialistic world and how you are going to cope up with that. So in addition to that, since as we discussed in the first slide, there are neurological symptoms as well, so sometimes our physician are very interested in the reduction of HbA1c and fasting blood glucose level, but they are never bothered to give B complexes, as stress is the case of hypermetabolism. And in diabetic patient, you see there is polyuria, so the water soluble vitamin are also lost, and that will produce neuropathic and neurological symptoms as well. So you have to take care of your patient, keeping in view this point as well. I hope now you understand. Thank you.